Hello, my name is Mike Willett at the Intertribal Council of Michigan's National Native Network. Welcome to the National Native Network webinar series on cancer risk reduction in Indian Country. This webinar is titled The Tribal BRFS Toolkit Presentation. This technical assistance webinar is being hosted by the National Native Network, which offers technical assistance and resources for commercial tobacco prevention and control throughout Indian Country and the Indian Health Service Clinical Support Center. Your presenter today is Kathy Edgerly, Program Manager at the Intertribal Council of Michigan. She has a Master of Science in Health Services with a concentration in Community Health from Independence University in 2006. We are pleased to offer continuing education credits for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated one contact hour for nurses. To obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey, which we will email out tomorrow. By the end of this webinar, participants will be able to describe the reasons which a tribal healthcare system might need to conduct a tribal-specific BRFS by May 30th, 2017, identify potential partners to assist with tribal-specific BRFS by May 30th, 2017, and reference the American Indian and Alaska Native BRFS Toolkit to meet the 5 phases of the BRFS timeline by May 30th, 2017. Please type questions into the question box on the lower right-hand side of your screen. Questions will be answered during the last few minutes of the webinar. And now at this time, I will go ahead and hand it over to Kathy Edgerly.
Hello. I'd like to start out by saying that it is an honor to have been invited to speak to you today about the American Indian Alaska Native BRFSS Toolkit. If you're not familiar with that acronym, I will be referring to it as the BRFS, which stands for Behavioral Risk Factor Surveillance System. Before I go any further, I want to share a little background on the National Native Network and the conception of the toolkit. The American Indian BRFS Toolkit project was a combined effort of the National Native Network, led by its board of 4 tribal agencies shown on this slide. The network is one of 7 national networks funded in a collaboration with the CDC's Office of Smoking and Health and the Division of Cancer Prevention and Control. The National Native Network provides culturally appropriate resources and technical assistance in order to identify and eliminate health disparities related to commercial tobacco and cancer. Some of the resources that they provide include bi-monthly webinars, such as this one, media and social media outreach, and their website, keepitsacred.org, contains a growing library of resources, including the Tribal Smoke-Free Policy Toolkit, the American Indian Adult Commercial Tobacco Program, the Cancer Registry Linkage Toolkit, and now the Tribal BRFS Toolkit is available. So, what exactly is the BRFS and why do we need a tribal-specific process? The BRFS is the world's largest ongoing standardized random telephone health survey conducted across the U.S. under the guidance of the CDC and has been conducted since the 1980s. It is the only source of state-specific population-based estimates of the prevalence of health behaviors, medical conditions, and preventive healthcare practices among adults. The BRFS remains as the gold standard of health behavior surveillance. The survey findings are usually used by public health agencies, academic institutions, nonprofit organizations, and others to develop programs that promote the health of its citizens. This slide shows an example of data collected from the 2014 State of Michigan BRFS, which shows state-to-nation comparisons. This chart does not show racial breakdowns, but annual state BRFS data charts typically only have data for Black, white, Hispanic, and other race categories. The American Indian population is underrepresented in many state BRFS reports as they make up about 2% of the nation's population. When states randomly select potential survey respondents from available phone numbers, their data set for American Indian Alaska Natives is usually very small. For example, in the state of Michigan, this typically results between 50 to 75 American Indian respondents from the entire state. This means the data set would be too small and could not provide statistically meaningful data. In addition, state attempts to oversample American Indians in the past have resulted in a higher number of respondents from urban areas, which does not adequately represent those American Indians living in rural areas. When the number of American Indian respondents is not large enough for reporting, the data is combined into the other race category or is combined into 3 years of BRFS data. This prevents tribal public health practitioners from accessing valuable data and from informing tribal programs specific to the needs of the unique population. Here is an example from the 2015 Michigan BRFS report, which shows the percentage of Michigan adults who have ever had asthma in their lifetime or who currently have asthma. Unfortunately, we are not able to see the specific results for those races included in the other category, such as American Indian, Alaska Native, Asians, and Pacific Islanders. This example shows how the state of Michigan BRFS data were combined for the years 2008 through 2010 in order to have enough American Indian participants to provide valid data. Notice that 3 years of BRFS data provided a data set of 200 completed surveys from the Michigan American Indian Alaska Native population. As you may guess, waiting for several years to get this information is not very helpful for effective and timely disease prevention programming. Fortunately, many tribes and tribal agencies have developed culturally specific methods to implement their own tribal specific BRFS, and they have achieved even better response rates than those seen by the state. Tribes are successful because they use community-based approaches along with tribal enrollment rosters, which greatly improves response rates and increases data accuracy. The region-specific BRFS provides tribes with valuable data which may be buried in their state survey. A tribal-specific BRFS in general will contain the same questions used by the state survey, so comparisons to the statewide data are available. However, the CDC does allow for modifications or additions of optional BRFS questions. Some tribes have added in questions about the use of traditional healers or have made revisions to allow for cultural considerations. The resulting valuable tribal-specific data may be used to support the need for chronic disease prevention programs, to guide policy or environmental changes, and to apply for funding opportunities. The Intertribal Council of Michigan is one example of a tribal consortium which participated in a tribal-specific BRFS. This BRFS was funded by the CDC's Steps to a Healthier U.S. program between the years 2004 and 2007, with 8 Michigan tribes. Participation was voluntary as each of the 8 tribes did not participate each year. It is important to know that the tribe was in the driver's seat throughout the process. We at the Intertribal Council of Michigan worked with them to gain approval from tribal leadership. Oftentimes, we were asked to present information about the BRFS and the value that it could provide to the community. Once leadership initial approval was gained, we created data sharing and confidentiality agreement templates in order to access de-identified phone numbers from tribal enrollment rosters for the BRFS sampling process. After we were granted permission to use phone numbers, we provided the numbers to our survey contractors at Michigan State University. We trained the university interviewers on cultural etiquette and language patterns specific to Michigan tribes. Once again, with the tribe in the driver's seat, we worked with them to notify their community of the upcoming survey. The tribes knew that it was important that their name and letterhead were used in any communications to their community. We served as the liaison between the university surveyors and the tribes to make sure that any issues were addressed as soon as they came up. And after the surveys were conducted, the data was sent to the Michigan Public Health Institute for analysis and translation. For our year 2007 tribal BRFS, a total of 592 surveys were completed with the participating tribes. This tribal-led process was very successful as compared to the state of Michigan's combined BRFS, combined for 3 years, which had only 191 American Indian Alaska Native surveys completed. This slide shows an example of the type of results seen in the tribal BRFS as compared to the state's BRFS. Adults from the 2007 Intertribal Council of Michigan BRFS had higher rates of obesity than the percentage which was reflected during the combined 2007 through 2009 Michigan BRFS. And you'll see 41% compared to 37%. The National Native Network created the Tribal BRFS Toolkit in order to capture and share lessons learned and valuable resources. This toolkit is not exhaustive in nature, but does provide several examples for BRFS which may be adapted for a tribal community. Several partners contributed to this toolkit in addition to the Intertribal Council of Michigan, including the California Rural Indian Health Board and the Southeast Alaska Regional Health Consortium. In the toolkit, you will find examples of lessons learned, a sample timeline, and also a variety of templates such as community outreach letters, sample subcontracts, and sample data presentations for those who may be interested in conducting their own tribal BRFS. The toolkit's timeline provides an estimate of the amount of time each stage of the survey may take. Of course, some tribal agencies may move through the process quicker than others. It will vary depending on the number and type of partnering agencies and the size of the tribe or region that is being surveyed. I'd like to provide a little more detail about each stage in the next few slides. Month 1 and the planning stage includes identifying necessary partners and resources. Tribal leadership approval is essential in order to gain permission to survey the community through the use of tribal member telephone numbers. Planning efforts should include which measures are necessary in order to gain this approval. Other important partners which should be identified include an expert survey organization such as a local university social research department. This surveying agency will conduct the actual BRFS and will gather and compile the raw data. After the data is collected, you will need an analysis expert or an epidemiologist to convert the raw survey data into a usable format. This partner may include a tribal epicenter or a public health institute. It will also be really helpful if you have access to someone who specializes or has the ability to take the report data and convert it into PowerPoints, infographics, or other dissemination products in order to return the BRFS results back to leadership or to the community. Okay, I'm pausing because there's some background noise. Thank you. Other resources include funding, which may be provided through existing health promotion grants, especially if these grants require the collection of population-based data. Some tribal agencies may have funds in their general budget which may be allocated for the purpose of conducting a tribal BRFS as part of a health needs assessment. It is also important to ensure that an experienced project manager will oversee the BRFS process within the tribe. This person may help to promote the survey to the community and also answer questions and concerns which may occur during the survey process. Lastly, you will want to determine if any other resources are needed. Be sure to consider staff time, support staff, also supplies such as computer, telephone, and mailing materials and cost for community outreach letters. Everything which was identified during the planning stage will now need to move forward in the month 2 preparation stage. For example, in order to gain approval from tribal leadership, it will be necessary to describe the benefits of participation in the BRFS. Tribal leadership will want to see the value of the survey in order to grant permission to use tribal member telephone numbers. A BRFS fact sheet or presentation may help describe the process and benefits. Other preparation activities include community outreach. Tribal agencies will want to inform their communities about the upcoming telephone survey. Outreach information may include tribal newsletters, tribal websites, individual mailings, or flyers posted at community events. In order to move forward with the survey, there will need to be a data sharing agreement and also memorandums of agreement between the participating tribe and the funder, and also the surveying agency or anyone who may come into contact with the tribal phone numbers. Lastly, in order to prepare for the dissemination and reporting of the BRFS results, a dissemination plan should be drafted. The plan should include the desired products to display the BRFS data and may include an executive summary, PowerPoint presentations, and community reports or infographics. Sample BRFS fact sheets, presentations, community outreach letters, and data sharing documents are all included in the Tribal BRFS Toolkit. Months 3 through 6 include all activities necessary to actually conduct the BRFS survey. Directly before the survey begins, the community will need to be notified through the predetermined community outreach methods. The tribal agency may want to conduct a brief cultural sensitivity training with the surveying agency. After these 2 activities are complete, the survey will begin. It may take up to 3 months for all of the surveys to be completed. This depends on the size of the community and the number of phone calls or survey attempts. Throughout this process, the tribal agency will stay in touch with the surveying agency to ensure that any concerns are addressed in a timely manner. After the survey is complete, the data analysis stage will begin. The surveying agency will notify the tribal agency that the surveys are complete, and then the selected epidemiology agency will translate and organize the data into usable information. The time frame for this phase depends on the quality of the data and the number of surveys collected. It may take several months. The last phase, dissemination, is very important because now the data may finally be put to use. The dissemination plan created during the preparation phase will guide how the analyzed BRFS data will be reported and shared depending on your intended audience. For example, you may provide a presentation or an executive summary to tribal leadership. You may decide to share information to the community or local health board through infographics or community reports. Or you may apply for funding utilizing data summary reports or other publications. There are many ways that you may use to disseminate the data depending on your specific needs. And I can tell you that the Intertribal Council of Michigan frequently uses aggregate tribal BRFS data for many of our grant applications and reports. And participating tribes also use their tribal-specific BRFS data for similar purposes. The American Indian Alaska Native BRFS Toolkit is available online at the keepitsacred.org website or at the following link. We have also hard copies available to send, and if you would like, the contact information is included on the Keep It Sacred webpage, or you may contact me at the email included on this slide. Thank you for your time.
All right. Well, thank you very much, Kathy. At this time, we'll go ahead and open it up for questions. If anybody has a question, feel free to type it into the question box. Just a couple of housekeeping things as far as our future webinars go. Let me see here. We do have a save the date for an upcoming webinar coming up on Wednesday, June 14th. Chris Johnson from the American Indian Cancer Foundation will be doing a webinar for the National Native Network. It'll be presented by the American Indian Cancer Foundation, National Native Network, and the Indian Health Service. And that topic is going to be on oral cancer and HPV. We're still waiting on more details to come in on the learning objectives and all the details on that. And we've also got another webinar scheduled for Tuesday, June 27th at 3 p.m. Eastern. Hillary Baca is going to present for us from the National Jewish Health on current updates for the American Indian Commercial Tobacco Program. So go ahead and pencil those down. Links are included on the PowerPoint presentation and on the National Native Network website if you wanted to go ahead and just kind of reserve the space and get yourself registered for that at the moment. Again, as Kathy had mentioned, the toolkit and the archive of the webinar is going to be available at keepitsacred.itcmi.org/resources/tribal BRFS toolkit. Or you can go to keepitsacred.org, look at the menu on the left-hand side, click resources, and it should be right there. So feel free to go ahead and check that out. Also, be sure to follow us on social media, facebook.com/keepitsacred, twitter.com/keepitsacred, linkedin.com/company/keepitsacred. And it looks like we do have a question that has come in here. This person says, great presentation. Question on representativeness of the data so collected. Since numbers are collected from community members, do you then randomly select who all will be interviewed? Kathy?
Okay, so if I understand the question properly, the numbers that we were able to collect for the 2004 to 2007 BRFS were representative only of the participating tribes. So the Michigan State University did do a random selection from those numbers. However, some of the participating tribes were very, very small. We were required to repeat the BRFS each year through the STEPS program. And so the surveyors had to basically use the entire list and redial them every year. So I'm not sure if I'm answering your question correctly, but they try to keep it as random as possible, but there were some issues. And yes, the data that I shared, the few slides that I did share, were only representative of the participating tribes, and they do not represent all American Indians in the state of Michigan.
All right, so if there's any follow-up questions, feel free to type them into the question box here. This other person asks, what other methods are survey data collected besides phone?
If you're referring to the BRFS, as far as I know, it's only telephone. I did participate in the REACH risk factor survey, and they did send a written survey. It was very, very similar to the BRFS. The questions were almost identical. So they did send a written survey, and they sent a small $5 incentive. I know that's not much, but at least it was something. And they just sent the $5 regardless, whether they returned it or not. But they did follow up with a phone call for those who did not mail back the survey. And I do know with their American Indian Adult Tobacco Survey, that was an in-person survey. And I'm not current on that project. I was involved a little bit, but I do know that we were pretty successful with our response rates in person. But that does raise the cost significantly. And I've never heard of a BRFS being conducted in person, but I don't think that would be a major issue if someone had the funds to actually send someone to that many doors.
Alrighty. Again, for folks that were interested in getting a copy of the BRFS Toolkit, you can visit the Keep It Sacred website, keepitsacred.org, or you can actually send us an email, NNN at ITCMI.org, or you can send Kathy an email as well, and we'll make sure to send out any hand copies or hard copies of the BRFS Toolkit. We also do have a Word document available as well if folks wanted to print that off and maybe modify it for their community's purposes. They can feel free to do that as well. And we do have a print ready PDF available on the website too. So we've got another question here. This person says, do you collect survey data for people who reside on the reservations or all tribal members no matter where they live? And then she wanted to clarify the question, only on tribes or tribal members everywhere. So, Kathy, I'll go ahead and let you answer that.
Okay. That's a really great question. They're all great questions. And I'll do my best. So if I don't answer it right, please let me know. The way I have seen this play out, and I've worked with a few of these BRFS projects, is it really depends on what you want. So when we have reached out to the tribes in Michigan and asked them if they wanted to participate, we gave them the option. Do you want to contact your tribal members that live throughout the United States, or do you want to contact those in your service area, those on your enrollment list? So they decided who they wanted to include and which phone numbers they wanted to release. So it really was up to each tribe. Every BRFS that I have participated in has been a little bit different. And then I also just want to follow up real quick and say, I am available by email for questions. I'm no longer, I'm working with the REACH program. I'm no longer with the STEPS program, but I am currently involved with our Office of Minority Health Tribal BRFS project. We are working with 3 tribes right now. So we're currently on the implementation phase of the timeline. and we're moving a little more slowly than I would like, but we're making it happen. It's very exciting. But I'm happy to share information or lessons learned. If you have any other questions, please don't hesitate to contact me.
Excellent. Thank you, Kathy. We'll go ahead and leave it open for questions for just a couple more minutes here. Again, we do want to remind everybody that we do have another webinar coming up on June 14th. Again, we're going to be talking about oral cancer and HPV. We've got partners at the American Indian Cancer Foundation that are going to help us out with that. Chris Johnson is going to be presenting for us. Wednesday, June 14th. That's going to be at the regular time, 3 o'clock Eastern. So feel free to hop on the website and get signed up for it. Details are still forthcoming, but if you wanted to just save your space and bookmark it, mark it in your calendar, all that kind of stuff, feel free. And then we do have another webinar coming up on Tuesday, June 27th, where we're going to be talking about the American Indian Commercial Tobacco Program. And Hillary Baca from National Jewish Health is going to help us out with that, give us some updates and everything. So far, I haven't seen any new questions pop up in the screen just yet, so we may be getting ready to wrap it up here. So feel free to follow us on social media. Our website is keepitsacred.org. If you have any questions, feel free to give us a shout at NNN at ITCMI.org. We will be sending out a auto-generated survey tomorrow, so feel free to get that filled out and send it back to us. We'll go ahead and get everybody set up with CEUs after that. We'll keep the survey open for about a week or so. And if you have any questions, feel free to give us a shout. Otherwise, I believe that's about it for our webinar. And thank you to everybody for attending. Have yourselves a wonderful Tuesday.